another bile leak. So it's a patient who has like metastatic cancer. A patient had a prior ablation, and at the site of prior ablation, there was a bile leak. Another case that I saw when I was a fellow. And this was the biloma at the margin of the bile leak. They had prior, so I sort of like showing off one of our IR colleagues and sort of what they can do. So the patient, this is during the patient came for a cholangiogram, and they injected contrast, and it communicates with the, where the bile leak is. And so the IR colleagues they were able to successfully occlude the bile leak by injecting like coil and glue. And so they were able to stop the bile leak, which was pretty cool because, this is less invasive than taking the patient to surgery for partial hepatectomy. So what I wanted to show was this about the bile duct anatomy variants that Aarti was referencing. So most of 70%. So 7 out of 10 people have this conventional anatomy. You have the left and right, and then the right branches into the anterior and posterior ducts. So the problem is these types. There's these variants where Aarti was telling the right posterior duct can arise directly from the CBD, and that could be problematic for our surgeons if they don't know that, because they can mistaken this for a cystic duct and accidentally clip it, which was done in Aarti's case. And the other anatomy variant that we need to be mindful of when we read MRCP is the low insertion of a cystic duct. So if the cystic duct inserts really low, then the surgeons may not know that and think that the main duct is the cystic duct and accidentally clip across it. So just reminders in terms of variants that are important for our surgical colleagues.
Nelly, I actually, I forgot I had a couple of slides related to this, but I did want to make one more point that's related to both of these cases. So let me see if I can share my screen. Can you guys see my screen?
Yes.
Yeah. Okay. So this is exactly what Nelly was talking about. So the right posterior duct is the one that's the most aberrant. So this is normally where it joins, but there can be like a confluence or triple confluence here where it goes right into the middle. It can cross over and insert onto the left duct. It can be low insertion like Nelly was showing, and it can insert onto the cystic duct, which we think might have been what was happening in my case. So when they clipped here, they also clipped the right posterior duct and caused it to start leaking. And then when it was leaking, they thought it was a duct of Luschka, and so then they clipped across that. And then another point I wanted to make was about this duct of Luschka, which is what Anu brought up earlier about a subvesical bile duct. So ducts of Luschka are thin, small ducts that drain from the bed, the gallbladder fossa, the liver that's adjacent to the gallbladder, directly into the gallbladder. A lot of them are just tiny little ducts or blind ending ducts. They don't serve that much of a purpose, but they can start leaking if you resect the gallbladder away from the liver. And so they can be a source of bile leak and peritonitis. They usually resolve if you just put a biliary stent in place. In this case, I was asking my surgeon, well, for our case, if you see bile leaking from this, this aberrant right posterior duct, how can you tell the difference between that and a more insignificant duct of Luschka? And he said that's why it's extremely hard to tell the difference. And unless you had a preoperative MRCP on every cholecystectomy patient, you would never have know that there was that aberrant duct. So it is pretty rare, the aberrant duct. And but when that injury happens, this is one of the more severe complications, is that instead of just being a duct of Luschka being, that they cauterize off or clip off, they're actually cauterizing that duct that's draining the entire right posterior sector.
That's cool. I didn't know that about that duct.
Yeah, and I guess the preferred term for duct of Luschka now is subvesical
bile duct. Yeah.
Yeah. Okay.